The real cost of NET treatment. What patients and families need to know. Hello, this evidence-based content is prepared by Sabur Khan, fellowship-trained consultant surgeon, and if you or someone you care about has been diagnosed with a neuroendocrine tumor, you're probably wondering not just about treatment options, but about the financial reality of managing this disease. I know that when medical bills start arriving alongside treatment plans, the stress can feel overwhelming. Today we're going to walk through the actual costs involved in NET treatment, what financial support exists, and, most importantly, what you can do to navigate this challenging landscape. Before we dive into specific numbers and strategies, let's establish what we mean by the economics of NET treatment. Neuroendocrine tumors require specialized long-term management that often involves multiple treatment modalities: medications, imaging scans, specialist visits, and sometimes surgical procedures or specialized radiation therapy. Unlike many cancers that might involve a defined treatment period, NETs often require ongoing surveillance and therapy for years, which creates a unique financial burden. Somatostatin analog medications like octreotide LAR and lanreotide form the backbone of NET treatment for many patients. These are not pills you take at home. They're injections administered monthly, typically at 30 milligrams for octreotide LAR or 120 milligrams for lanreotide. That's about one injection every 4 weeks indefinitely for as long as the treatment remains effective. The CLARINET and PROMID trials established that SSAs don't just control symptoms, they actually slow tumor growth. Each monthly visit requires a healthcare professional trained in giving these injections properly. Octreotide LAR is given intramuscularly, while lanreotide is a deep subcutaneous injection. Beyond the medication cost, you're looking at regular clinic visits, which means copays, time off work, and transportation costs. Some patients develop pancreatic insufficiency from long-term SSA use. That's when your pancreas doesn't produce enough digestive enzymes. This happens in almost 1/4 of patients, usually after 6 to 24 months of treatment. Surgery is the cornerstone for many NETs, but is associated with risk. Metastases may require liver-directed therapies like ablation, or TAE. These specialized treatments are often only available at major centers, necessitating travel and adding to the overall financial burden. Let's start with one of the most effective but expensive treatments, PRRT, specifically using Lu-177 dotatate. This treatment has transformed outcomes for many NET patients. The NETTER-1 trial, the landmark study that proved PRRT's effectiveness, involved 4 cycles of treatment given at 8-week intervals. PRRT is administered at specialized centers, which means you're not just paying for the medication itself, but potentially for travel, accommodation, and time away from work. PRRT is now an officially registered therapy for certain types of NETs following the NETTER-1 results, which showed it significantly extended the time before disease progression compared to high-dose octreotide. This registration status is crucial because it affects insurance coverage and reimbursement. If you're supporting someone through this, understand that PRRT typically requires 4 hospital visits over several months, and each visit might involve 2 to 3 days of treatment and observation. Let's talk about something that doesn't always get the attention it deserves in cost discussions: the frequency and sophistication of imaging required for NET patients. Specialized imaging using Gallium-68 dotatate PET CT scans has become the gold standard for detecting and monitoring NETs, because these tumors have somatostatin receptors that light up on these scans. But here's the reality: these aren't your standard CT scans. For patients with metastatic non-functioning pancreatic NETs, guidelines recommend imaging at 3 months initially, then every 3 to 6 months for 2 years. After that, if disease remains stable, the interval can be lengthened to 6 or even 12 months. We're not talking about 1 or 2 scans here. Think about it. At minimum, you're looking at 6 to 8 specialized scans in the first 2 years alone. Each PET CT scan is significantly more expensive than conventional imaging. The European Neuroendocrine Tumor Society explicitly states that NET patients should be referred to ENETS centers of excellence, or centers with high expertise in the field. These specialized centers have regular NET tumor boards, with expert panels bringing together surgeons, oncologists, endocrinologists, radiologists, nuclear medicine specialists, and pathologists. This likely means your treatment isn't happening at your local community hospital. For patients requiring carcinoid heart disease evaluation and treatment, there is an additional layer, a dedicated CHD multidisciplinary team that includes NET physicians, cardiologists with CHD expertise, cardiothoracic surgeons, cardiac anesthetists, and specialist nurses. This comprehensive care improves outcomes, but requires access to highly specialized centers. The complexity of NET management genuinely requires this level of expertise, but the geographical and financial implications are real. One of the most challenging aspects of NET treatment economics is that the optimal sequence of treatments hasn't been fully established. This creates both clinical and financial uncertainty. Research tells us there are several effective treatment lines available. SSAs, PRRT, targeted therapies like everolimus and sunitinib, and various chemotherapy regimens. But which order makes the most sense? The data are still emerging. Your treatment team might recommend starting with one approach, but there's genuine scientific uncertainty about whether that's financially or medically optimal compared to alternatives. You might start SSA therapy, then add PRRT later, or you might be considered for upfront PRRT in certain situations. Each pathway has different cost implications and insurance coverage challenges. This uncertainty makes financial planning difficult. For patients with advanced NETs, targeted therapies like everolimus, an mTOR inhibitor, or sunitinib for pancreatic NETs represent important treatment options. The RADIANT-4 trial established everolimus's role in non-functional NETs of lung or gastrointestinal origin, showing it extends progression-free survival. These are daily oral medications, not occasional injections, which means 30 pills per month, month after month. There is another layer here: managing side effects. Everolimus can cause stomatitis, mouth sores, infections, and metabolic issues that require additional medical attention and, sometimes, additional medications. Sunitinib can cause fatigue, hand-foot syndrome, and cardiac issues requiring monitoring. So you are not just paying for the cancer medication, you are potentially paying for supportive care medications and more frequent medical visits. Let's address something practical. Not everyone lives near an ENETS center of excellence. Follow-up for NET patients should occur in specialized NET centers with regular tumor boards, according to consensus guidelines. If you live in a rural area or smaller city, this might mean traveling hundreds of miles for initial evaluation, treatment, and ongoing monitoring. Think about a typical year of NET treatment. Monthly SSA are a class of drugs used to treat certain tumors. Injections, potentially local. Quarterly specialist visits at the NET center. Imaging every 3 to 6 months. Specialized scans at the NET center. Tumor board reviews requiring records transfer. If PRRT is a type of targeted cancer treatment that uses radioactive drugs to target and kill cancer cells, is recommended 4 separate trips for treatment cycles. That's potentially 8 to 12 trips to a specialized center annually. If you are in the US, contact your insurance company's case management department. Large insurance companies have case managers for complex high-cost conditions. Ask specifically, do you have a case manager who can help coordinate my NET care? What are my specialty medication costs for octreotide, lanreotide, everolimus? Is there a difference in coverage between in-network NET centers? Do you have any programs to help with travel costs for specialty care? Given that the optimal sequence of NET treatments isn't fully established, can we discuss the financial implications of different approaches? If we start with SSA therapy now, what would trigger moving to PRRT, and what would that transition look like financially? Are there clinical trials for which I might be eligible? I understand that trial participation can sometimes reduce out-of-pocket costs, since the study sponsors cover certain expenses. Based on my specific tumor characteristics and current disease status, can we develop an imaging schedule that balances good surveillance with cost management? If my disease has been stable for 18 months, can we extend to less frequent scans? As patents expire on NET medications, are there, or will there be, lower-cost biosimilar options available? Can you keep me informed about these? Each trip potentially involves gas or airfare, parking, meals, potentially overnight accommodation, lost wages for days away from work. For families where one person needs to accompany the patient, you are doubling some of these costs. These aren't covered by insurance, yet they are absolutely necessary for accessing appropriate care. Now here's your bottom line. Let's talk about the 4 categories of action you can take to manage NET treatment costs. Document everything systematically. Start a binder or digital folder with every bill you receive, even if it's going to insurance. Explanation of benefit statements from your insurance, receipts for travel, parking, and accommodation, and a mileage log if you're driving to appointments. Medical expenses above 7.5% of your adjusted gross income may be tax deductible. Research pharmaceutical patient assistance programs this week. Companies manufacturing NET medications often have programs for patients who qualify financially. Novartis, Ipsen, and Advanced Accelerator applications all have patient support programs. Applications take time to process, so start early. Connect with NET patient foundations. Organizations like the NET Patient Foundation and Carcinoid Cancer Foundation provide up-to-date information on treatment costs, connection to other patients, and sometimes direct financial assistance. Seek financial counseling immediately if you're facing any of these situations. Medical bills exceeding what you can pay, collection notices for medical debt, considering bankruptcy due to medical expenses, forgoing recommended treatment due to cost. Contact your hospital's financial counseling department, nonprofit credit counseling services, or medical billing advocates who can review bills for errors and negotiate. Warning signs. Treatment costs are becoming unsustainable. You're using credit cards to pay for medical care. You're skipping medications or treatments due to cost. You're unable to maintain other essential expenses, such as housing and food. Your savings are depleted with no end in sight for treatment costs. If you are in the US, you may wish to pause this slide to navigate the insurance complexities. Here are some practical support pointers for the US. Corporate Angel Network, American Cancer Society Road to Recovery, Joe's House. A specific example. If you need PRRT and the center is 500 miles away, requiring 4 trips over 6 months, you'd need 8 round-trip flights, or 4,000 miles of driving, 12 to 16 nights of accommodation, meals for these extended trips, and potentially 8 to 12 days of lost wages. NED treatment involves substantial ongoing costs across medication, imaging, specialist care, and logistics that create a long-term financial burden for patients and families. Your next step this week: call your insurance company's case management line and ask specifically about NED care coordination and specialty medication costs. This information is for education. Always discuss your individual situation and financial concerns openly with your healthcare provider and care team. I've outlined several reputable resources here which you may find valuable for further information on NED treatment economics and financial assistance. Thank you for watching.